therapy evolution. This is the table showing how these therapies were there. First, we had interleukin 1992, then sorafenib in 2005. This is the first time something targeted came up. Then Sunitinib 2006, then temsirolimus 2007. Then gradually bevacizumab, everolimus, pazopanib, axitinib, nivolumab, cabozantinib, lenvatinib, and then immunocombinations like nivolumab, ipilimumab, and pembrolizumab, axitinib. So mechanism of action. We have basically anti-VEGF drugs, mTOR, anti-mTOR drugs, and immunotherapy. The VEGF is important from both the neoangiogenesis point of view. So how this bevacizumab targets this VEGF receptor on the cell of endothelial cells, and Sunitinib, sorafenib, pazopanib, axitinib, the small molecules, they target the tyrosine kinase domain. Tumor cells also express VEGF, so it's also important. In addition, cabozantinib, it targets VEGF plus MET. Downstream from this VEGF, we have RAS, RAF, MEK, ERK pathway, and PI3K, mTOR pathway. So everolimus and temsirolimus targets this mTOR pathway. We also have immunotherapy, which basically boosts the immune response of the body against malignancy, which I will discuss later. So individual agents, interleukin, it was the first initial active agent. A high-dose bolus therapy was required. It is basically a form of immune therapy, but because it's not targeted, it's associated with severe toxicity. Responses, however, can persist for many years. A majority of complete responders remain free of relapse for long term. But these are the various toxicities, and these are severe toxicities requiring intensive care, and only few centers to practice this kind of therapy. Interferon was there, it was less toxic, but overall response rate was only 15%. Median time to response was 4 months, and most responses were partial and rarely persisted beyond 1 year. In a meta-analysis, which included 4 studies with 644 patients, treatment with interferon alpha was superior to controls, with odds ratio for death at 1 year of 0.56 and hazard ratio for death 0.74. Median improvement in OS was very modest at 3.8 months. Then came bevacizumab, which is an anti-VEGF antibody. Then it was targeted along with interferon. So the trial was bevacizumab plus interferon versus interferon plus placebo. If you see the overall survival here, there's hardly any difference. It was 23 versus 21 months, and it was not significant, even though bevacizumab prolonged the progression-free survival. So there was some interest in this therapy for some time, but as the TKIs came up, it fell out of favor. So then came Sunitinib versus interferon study, which showed that the response rate was 47 versus 12%. It was quite big. The PFS was 11 versus 5 months. It was significant. OS, there was an improvement of 5 months, but p-value was not significant. 0.05, just about borderline. Bevacizumab I have already discussed. Then pazopanib and temsirolimus were there. I will discuss them later. So this is the trial of Sunitinib versus interferon. If you see the PFS, there is a big gap, 11 versus 4 months, and based on this, Sunitinib became the standard of care. But it had a lot of toxicity: diarrhea and vomiting, fatigue, hypertension, hand-foot syndrome, leukopenia, neutropenia, thrombocytopenia, increased lipase, amylase. These were all very troublesome adverse effects, and these are the most common. There are a host of other things which are not that difficult to manage. But these things may be limited the duration of treatment and the dose. This is the standard dose of Sunitinib, 50 mg, 4 weeks on and 2 weeks off. But people found that the toxicities could be reduced if you give a schedule of 2 weeks on and 1 week off. The dose intensity is much better, and the patient will tolerate the therapy for a longer duration of treatment and obviously gain a longer benefit. This is the hand-foot syndrome of Sunitinib that I was talking about. Blisters and peeling out of skin is very common. So one need to be aware of this, and you need to check the patients frequently, and we need to treat them with various moisturizing creams and also steroids, avoidance of pressure, etc. But then came pazopanib. This is the PFS of the pazopanib study, where the comparator was not interferon but placebo. This is the criticism of the study because Sunitinib compared against interferon and what came it was a placebo. But the median PFS was the same in cross-trial comparison, but 11 months, and for placebo it was 2.8 months. So the hazard ratio was again significant, 0.4. So we have two TKIs. Both seems quite effective. So do you want to use pazopanib or Sunitinib? So people compared the two in a study, which is the COMPARE study. Clear cell patients are only included and randomized between pazopanib and Sunitinib, the standard Sunitinib schedule of 4/2, that is 4 weeks on, 2 weeks off as followed. The PFS, the primary endpoint, was no difference between Sunitinib and pazopanib. It was 8.4 versus 9.5 months. But in toxicity, there is a lot of difference. Patients treated with Sunitinib as compared to pazopanib have higher fatigue, higher hand-foot syndrome, and higher thrombocytopenia, and those are all quite significant. Those with pazopanib had higher incidence of increased ALT, 60% versus 43%. Quality of life was, for the first 6 months of therapy, favored pazopanib for all comparisons. In all these 11 points, like fatigue or soreness in the mouth, throat, and foot syndrome or feet during the first 6 months of therapy were better with pazopanib. So it seems, at least according to this 4/2 schedule, Sunitinib has more toxicity than pazopanib. Obviously, you can reduce.
Dr. Ghosh, we're stuck again. The screen is not moving.
Not able to hear you also.
No. So last time also it happened. His connection had gone off. Let me call him again. In the same thing. Just a second. I'm sorry, guys. He's re-logging in. So sorry, patchy internet with him probably. But what I could make out till he joins is that, and Dr. Puneet Aluwalia is with me, and Dr. Rajat Sai is with me, and people who want to chip in can join in. So Dr. Saurabh Tiwari, Dr. Ghosh is rejoining in. So please bear with us till he rejoins. What I deciphered was that we can put the MSKCC and the IMDC criteria to define the risk stratification, and then we can decide for surgery versus no surgery. I am sure he'll come to that. But of the two drugs that we can see is Sunitinib and pazopanib, right? And the last slide that I saw was that pazopanib is more tolerable toxicity-wise as compared to Sunitinib. Is that right, Dr. Rajat?
Absolutely. So you've got it spot on.
Okay.
So yes, pazopanib has lesser toxicity as compared to Sunitinib, but Sunitinib in the two weeks on 1 week off schedule is also equally efficacious and comparatively well tolerated. it's now Dr. Indranil would also be talking about the combination of immunotherapy and the VEGF inhibitors. So that is the next line of treatment which he would be talking about once he rejoins.
Okay, so just
I have joined.
yeah, Puneet, go ahead.
Yeah, I have joined. Can you make me go ahead?
Yes,
Oh, sorry.
Indranil has come back. Yeah.
Okay, great. Just let me see where you are. Okay, I saw you. So you can start sharing, sir. The last slide that we saw was the side effects of Sunitinib and pazopanib.
Yeah, I will start. Yeah, so quality of life seemed better for pazopanib, at least for the first 6 months. So next came temsirolimus, which was studied only in poor risk patients. Here in this study, if you look, the temsirolimus has a median OS of 10.9 months versus interferon 7.3 months. Based on this, temsirolimus is overall survival, not the PFS as the other studies. So in poor risk, as you can see, the median OS is still quite poor. With temsirolimus, it's around 11 months. But temsirolimus is not available anymore in India, so we need to think what we need to give to these patients. Then I will discuss few studies in brief. These are not available in India. Cabozantinib. It is another multi-targeted TKI. It was studied against Sunitinib for poor and intermediate risk patients in a phase 2 study. In this study, cabozantinib median PFS was 8.2 months versus Sunitinib 5.6 months, and it was significant. So this is one option, not the preferred one, but still it's an option for first-line patients. So Sunitinib, pazopanib, or bevacizumab and cabozantinib have shown improved PFS in first line among the anti-VEGF drugs. Pazopanib has a similar efficacy, a different safety profile, and higher quality of life scores compared to Sunitinib. Cabozantinib is active in first line for intermediate and poor risk patients, but its phase 2 data and OS is not matched. Now, second line treatment after failure of anti-VEGF. So we have everolimus. We had actually everolimus for a long time. Those who had received prior VEGF TKIs, 1 or 2 lines were included in this study, and they were randomized to everolimus versus placebo. The PFS was 4.9 versus 1.87 months, still quite poor, but it was improvement over placebo. Overall survival, no difference was there. Based on this, everolimus was the standard of care for some time. Also, we had axitinib. Sorafenib was also an option. I have not discussed. Sorafenib data was already there. It's another VEGF TKI. So then axitinib, a newer TKI came, and it was compared in this second line setting as compared to sorafenib. And as you can see here, the median PFS was 6.7 versus 4.7 months in sorafenib. So there was an improvement, and this was against sorafenib, not like everolimus, which was against placebo. So based on this, axitinib also became a standard of care. Then came cabozantinib in second line. It is a phase 3 study against everolimus. So they have taken another standard of care, everolimus, and compared cabozantinib against that, and found that cabozantinib overall improved the overall survival, and the hazard ratio for death was 0.67. So a 33% improvement in survival was there with cabozantinib. So based on this, cabozantinib also became a standard of care. Then came another combination, lenvatinib with everolimus. Here the comparator was everolimus, and they compared it with one of lenvatinib single agent and lenvatinib plus everolimus. The doses were used, everolimus 5 mg and lenvatinib 18 mg. They found that only the combination arm was better than everolimus. It was 14.6 months of median PFS versus 5.5 months with everolimus. So this was again a big jump, and the hazard ratio was 0.37. This is for PFS, not OS. Based on this, lenvatinib everolimus was also an option. So axitinib, lenvatinib everolimus, cabozantinib, and this everolimus alone. These are all options. Then came another game-changing group of therapy, that is immune checkpoint inhibitors. Here, basically, if you see the interaction between T cell and the tumor cell, PD-L1 on tumor cell interacts with PD-1 on T cell, and this interaction leads to inhibition of T cell response. Similarly, CTLA4 on T cell binds with CD80 on tumor cell, leads to inhibition of T cell response. On the other hand, T cell receptor antigen MHC binding and CD28 CD80 binding leads to enhancement of T cell reaction. So if we can block these inhibitory pathways by PD-1 inhibitors, PD-L1 inhibitors, or CTLA4 inhibitors, then we can boost the immune response of the body against cancer. So this nivolumab, which is an anti-PD-1 antibody, it was tried in comparison to everolimus, which was the then standard of care. Nivolumab 10 mg per kg, higher dose was used in this study. Body weight 10 mg per kg every 2 weeks. These patients all received 1 or 2 lines of prior VEGF treatment. So this is the overall survival curves. If you can see here, till almost 50% of the events, there was no difference. After that, the curve separated, and nivolumab at long term is showing a much better survival. Median was 25 versus 19.6 months with a hazard ratio of 0.73. And the median is also improved, but if you see a 2-year mark, it's a quite encouraging responses. So few patients with nivolumab have done really well. And the grade 3-4 adverse events were much less compared to everolimus. Anemia, hypertriglyceridemia, hyperglycemia, stomatitis, fatigue is a much more common with everolimus and much less with nivolumab. So not only it's a better drug, it's better tolerated also. So second line options after prior VEGF treatment. So you have treated the patient with sunitinib or pazopanib. Disease progresses. You have mTOR inhibitor everolimus. You have VEGF TKI axitinib, a PD-1 inhibitor nivolumab, MET and VEGF multi-targeted TKI cabozantinib, or VEGF TKI plus mTOR inhibitor lenvatinib plus everolimus. After third line, similarly, you have to see what drug has not been used already, and you can use that drug. Now, immunotherapy combinations. We learned about immunotherapy single agent nivolumab. Now, what happens if nivolumab plus ipilimumab is given? Nivolumab is anti-PD-1, ipilimumab is anti-CTLA4. If you combine both pathways, is it working well? So this combination was tried in treatment naive. So now we have come back again to first line. Stratified by IMDC criteria and the region, nivolumab 3 mg per kg IV plus ipilimumab 1 mg per kg 3 weekly for 4 doses. Then nivolumab 3 mg per kg 2 weekly to continue versus sunitinib. This is a robust study taken a standard of care sunitinib and compared with an immuno combination. You see the overall survival, there is a big gap. Nivo-Ipi, it's not reached median survival versus sunitinib, 26 months. And if you see 18-month overall survival, 75 versus 60 months. So hazard ratio for death is 0.63. It is quite significant. For intermediate to poor risk, this was a pre-specified primary endpoint, not reached versus 26 months. So for the bad patients, the benefit is still there, hazard ratio 0.63. But for patients with favorable risk disease, it was not a co-primary endpoint, it was an exploratory analysis. There was no significant difference in median OS, both groups not reached. And overall response was for 52% versus 29% in favor of sunitinib. So we have every reason to believe that there is no need for this highly expensive combination for first-line therapy in favorable risk patient. For that, sunitinib is good enough. But for intermediate to poor risk, it's definitely looking better than sunitinib. Another combination has been approved, pembrolizumab plus axitinib. Again, this is the unique combination. Not unique now, many combinations are coming like this. Pembrolizumab is an anti-PD-1 combined with axitinib, which is an anti-VEGF. So two pathways are targeted versus again comparator arm sunitinib. If you see here, pembro plus axitinib, the overall survival is much better. Here, the blue curve, pembrolizumab plus axitinib as compared to sunitinib, hazard ratio was 0.53. So again, this is showing a similar magnitude of benefit like Nivo-Ipi combination. And if you see here the subgroup analysis, IMDC favorable also, the hazard ratio 0.64, intermediate 0.53, and poor 0.43. PD-L1 combined positive score less than 1 or more than 1, it did not matter. So all subgroups benefited from this combination. So based on all I have discussed for metastatic clear cell carcinoma, in clear cell renal cell carcinoma, for first line therapy, in a favorable group, our preferred therapy should be either sunitinib, pazopanib, or pembrolizumab plus axitinib, which looks slightly better. Cabozantinib is also an option from the phase 2 study. For poor and intermediate, ipilimumab, nivolumab comes into the picture. Also pembrolizumab plus axitinib and cabozantinib, these are preferable. Pazopanib and sunitinib are less preferable because the trials of these drugs did not include poor risk patients. I would have included temsirolimus in this, but unfortunately that is not available in India. For second and third line, preferred cabozantinib, nivolumab, or ipilimumab, nivolumab. Others, all the other drugs which I have discussed will come in the others. Non-clear cell, we don't have time to discuss the entire gamut of non-clear cell. A few points. Non-clear cell has got a worse prognosis. This is from IMDC chart review. OS after one targeted therapy. At least the patients who have received one line of targeted therapy, their overall survival for clear cell was 22 months, non-clear cell 12 months. So there is a big difference. Non-clear cell is doing worse. But not all non-clear cell are the same. If you see here, clear cell and chromophobe renal cell are almost the same. Papillary renal cell worse than that. And unclassified, which includes the others most likely, are poor. So among non-clear cell also the histology matters. The IMDC risk model also applies to non-clear cell. The same IMDC for clear cell will work also in non-clear cell. If you apply this criteria, if you see here, favorable has got better prognosis, then intermediate, then poor. So you should use the same criteria. But targeted therapies are less effective in non-clear cell. The overall response rate of non-clear cell target therapy, 10.5% versus 14.8% in clear cell. Median PFS 7.4 versus 10.5. Median OS 13.4 versus 15.7. So with same drug, if you apply, there is a meta-analysis of 49 studies with lot of patients, more than 7,000 patients, where non-clear cell was 1,200 patients. So this is a large database confirming the targeted therapies don't work that well. I will discuss only the summary for this patient, not the evidence. For patients with advanced non-clear cell, VEGF-directed therapy is preferred. Sunitinib is preferred. Pazopanib is another option. For poor risk patients, temsirolimus is preferred. For collecting duct or renal medullary, there is a role for cytotoxic chemotherapy, which you can go and read about it. Erlotinib is an option for papillary renal cell. For MET amplification-driven papillary renal cell, crizotinib is also an option. And checkpoint inhibitors is also coming up in a big way in non-clear cell NSCC. The last part, role of nephrectomy and metastasectomy. Cytoreductive nephrectomy is historically very important because randomized trials have shown a benefit of cytoreductive nephrectomy as compared to cytokine therapy alone. Cytokine therapy, that is interleukin and interferon, when combined with that, cytoreductive was very good. Several targeted therapies are now mostly used and not those cytokines. And retrospective studies have shown that, okay, cytoreductive plus targeted may be better. So is it really better? That was studied in this trial of sunitinib alone or after nephrectomy in metastatic RCC, a phase 3 non-inferiority design. So the question was, is sunitinib non-inferior, sunitinib alone non-inferior to sunitinib plus nephrectomy or not? Because we want to avoid nephrectomy. So In arm A, they were nephrectomized, followed by sunitinib. Arm B, direct sunitinib. Primary endpoint of overall survival. Overall survival, this red one is actually sunitinib alone, and the blue one is sunitinib plus nephrectomy. So it was non-inferior. Sunitinib alone was non-inferior to sunitinib plus nephrectomy. Similarly for PFS. Overall survival 13.9 in nephrectomy arm, 18.4 in non-nephrectomy arm. Hazard ratio not significant. Intermediate risk 19 versus 23 not significant. Poor risk 10 versus 13 not significant. Now obviously no patients or good risk here. This should be another question which you should answer. Why no patients are good risk in this case? Tumor response outcomes. Clinical benefit ratio, I will show only this for nephrectomy and sunitinib. Clinical benefit means disease control, complete, partial or stable disease beyond 12 weeks. That was 36% versus 47%. So if you see the nephrectomy plus sunitinib, clinical benefit 36 months and sunitinib alone 47 months. So it's sunitinib is not inferior. Sunitinib alone is non-inferior to cytoreactive nephrectomy, followed by sunitinib for overall survival, both in intermediate and poor risk. Clinical benefit was also significantly better in sunitinib alone arm. Cytoreactive nephrectomy should no longer be considered standard of care in intermediate and poor risk groups, at least when medical treatment is required. So that brings us to the question that this trial enrolled patients with high metastatic volume. On an average, patients had 40% or more of metastatic disease and 60% or less of the kidney disease. So this trial should not be used to abandon cytoreactive nephrectomy in patients with very low volume metastatic disease, a good performance status, and intermediate risk. Because in these patients, if you remove the kidney and treat the metastatic disease by local therapy or maybe just observe without any systemic therapy, the patient can have a long disease-free interval. As I showed in my first trial, which I showed of active surveillance, that same concept comes into picture. We need to select our patients properly. What about metastasectomy or local therapies? Metastasectomy implies the surgical removal of the metastatic sites. We can also treat them locally, like WBRT or like whole brain radiation for brain metastasis, external beam radiation to say any other sites of metastasis, stereotactic radiosurgery, stereotactic body radiation. These are all options. So these are options, but patients should be selected after MDT review. A meta-analysis of 16 studies, these are all observational and retrospective studies, point toward a benefit of complete metastasectomy or overall survival and cause-specific survival, but there is obviously a selection bias because only the good prognostic patients will be taken in these studies, and the results have to be interpreted with caution. If you have done a metastasectomy and the patient is rendered NED, there is no evidence of disease, a single lung metastasis you have taken out, then no systemic treatment is recommended after that. So you need to just observe the patient. If more sites of metastasis come up, then only give systemic therapy. So selection for metastasectomy or local treatment in a MDT should always be done. Good performance status, solitary or oligometastasis, metachronous disease with disease-free interval more than 2 years. So we have resected the kidney as an upfront therapy. Later on, the patient developed metastasis after 2 years or a very limited site. That patient is a good candidate. Absence of progression of systemic therapy. Maybe you have started systemic therapy and the patient has not progressed on that. And there is only limited sites. You can treat them with local therapy. Low or intermediate performance grade. Feasibility of complete resection. So you should do a resection only if you can resect everything. So to conclude my talk, comprehensive staging is very much important because then only you will identify metastasis. Risk stratification is the mainstay. Unless you do the risk stratification, you cannot select the treatment. Systemic therapy is the cornerstone of therapy. VEGF TKI, immune checkpoint inhibitor, and mTOR inhibitors are the major group of drugs. Toxicity management is very important with all of these drugs as they have very unique side effect profiles. Cytoreductive nephrectomy can be done in very few selected patients, not as a routine. Metastasectomy and local therapies for metastases are also for very selected patients. So with that, I will end my presentation. We can discuss few questions.
So thank you very much, Dr. Indranil, for a fantastic and a very concise presentation on RCC. It is actually the data is actually getting very exhaustive nowadays with the option of immunotherapy also coming into the picture. And we have quite a lot of questions, and I think so our students are intelligent enough that they are themselves are answering their questions which have been posed by their colleagues. So a few questions which are standing out is basically in clinical practice we come across the sarcomatoid variant of clear cell carcinomas. They traditionally in our clinical practice fare very poorly. So what is Dr. Indranil, your opinion of treating these patients of sarcomatoid histology?
Yeah, my take is that during our residencies and after that also we learned that these were to be treated with a gemcitabine with adriamycin chemotherapy. But nowadays, sarcomatoid, just by the histology, it won't matter much. We need to treat them as per the general guidelines for RCC only. That is my current understanding.
Correct. Basically, the guidelines do not change, but yes,
Yes, sarcomatoid is not a specific histology of RCC. All those non-clear cells, they are specific histologies. Whereas sarcomatoid is just a variant of clear cell.
Correct.
So we should treat them as per current clear cell guidelines.
Correct. So another thing which one of our students have asked is basically there was a question on adjuvant therapy for RCC. Suppose we have done a successful means nephrectomy for a patient. Do we subject this patient to Sunitinib? I think so. You have taken up this topic in your presentation also.
No, I did not include adjuvant therapy because the topic was metastatic. So there was only some BFS benefit and lot of toxicities were there, and the overall survival was not improved. So it's not the standard of care.
Yeah, so actually it is not one of the standards of care, and it actually gives the patient a lot of toxicity without much of a good any PFS or a OS benefit. So as of now, we are not using adjuvant Sunitinib in our patients. So another thing is you have obviously answered this question. Papillary type 1 or type 2 is considered to be a high risk histology or not. So you had presented one of your slides that
papillary is intermediate.
Papillary is intermediate, definitely, and undifferentiated is the worst of the lot. Papillary is intermediate, and clear cell definitely fares better than the papillary variants.
Also, the collecting duct and medullary, that is also having a
yes. And I don't think so. There are any further questions.
What if there is a metastatic RCC with symptoms of hematuria and pain?
Yes.
Yes. Surgery is definitely indicated in that as a palliative nephrectomy.
Any? Dr. Puneet would like to comment on the role of cytoreductive nephrectomy. He's a uro-oncologist. And Dr. Puneet, please.
Yeah, hi, Dr. Indranil. I'm a uro-oncologist, senior consultant in MAX. So most of it you have covered in your talk. Just a bit more in the Carmina trial. Actually, according to me personally, I don't feel Carmina has changed much as to what we were practicing earlier. Only thing is it has added the evidence. So good risk, there are not many patients. Rather, it was only intermediate and poor risk patients in the Carmina which you have told. So good risk, we are doing cytoreductive nephrectomy. And intermediate, even in ASCO 2019 update, intermediate risk, if it is a one intermediate risk, then the overall survival is around 31 months as compared to 25 months. So if it is intermediate risk factor 1, then you can still do cytoreductive nephrectomy as compared to 2 risk factors. And second thing in Carmina, if you see, if you compare the patients within the Sunitinib alone, for the patients who underwent only Sunitinib compared to the patients who underwent delayed nephrectomy, even those patients did well than the patients who underwent Sunitinib alone. So I guess poor risk, yes, there is no role of cytoreductive. Intermediate risk factor 1 and good risk, there is still a role of cytoreductive nephrectomy. Only thing which I would want you to comment upon is that since we use IMDC criteria or MSKC criteria earlier which we were using, both of them have not included the bulk of the metastatic sites. And plus any metastatic site which is particularly vulnerable to recur or where the surgery may not be much helpful. You have added in MSKCC that the more than 2 sites is a more burden. So if you can comment, or even Dr. Rajat, you can put your thoughts on this.
I would add only one thing that if a patient presents with de novo metastasis, it basically becomes by default at least MDC1, so intermediate risk. So basically, when you are talking about good risk, you are talking about that patient only. Those who have only that one as a risk factor, because if a patient presents with de novo, then the interval is less than 12 months, so it becomes intermediate risk. So if that is the only risk factor is there, that it's a de novo metastasis, and all the other risk factors are negative, which is basically what you have told. IMDC only one risk score. Those patients and those who have a very limited disease burden, they are consider, and preferably always in a MDT.
Correct. One interesting question, Dr. Puneet and Indranil both can take together. Any CT criteria to avoid biopsy in an RCC?
So traditionally for urologists or uro-oncologists, biopsy is done if you are suspecting abscess, a lymphoma, or a metastatic disease, or if it's a metastatic disease, means if the burden is too much and you're planning for a targeted therapy, then you have to do. In these 3-4 situations, you need to do a biopsy. So if you're going to do cytoreductive nephrectomy, then there is no role of biopsy.
Okay. And if suppose we are going to start the patient on upfront TKI, definitely we need a biopsy.
Absolutely, yes.
We need a biopsy.
Yes.
There's no question about that. Dr. Pramod Kumar has asked a pertinent question. Any change in TKI preference if the patient has upfront brain metastasis? Do we have any choice of one TKI over the other? Indranil?
No, I am not aware of any data on that.
I also am not aware of any particular brain penetration of one TKI over the other. So we can definitely choose from either Sunitinib or pazopanib in these cases. Yeah. Yes.
So, Dr. Rajat, there are some questions on the YouTube channel which you or Dr. Indranil can't see, so I'll read them out. Dr. Aarti Sani is asking, what is the role of SBRT for metastatic renal cell cancer? I think Puneet can also chip in this. So I think she's asking about SBRT for metastatic renal cell cancer. Probably she's talking about the kidney, because SBRT for brain would definitely be would have a role. But what about SBRT for metastatic, in a metastatic setting, probably for the renal lesion? How about that?
Renal,
Not only renal, for lungs also it can be done for other sites. If there is a solitary 1 or 2 lesions and you want to treat them locally, then SBIP is a good option.
The dictum is in an oligometastatic state, if we are able to ablate all the primary as well as the metastatic lesions either by surgery or by stereotactic radiation therapy, it is preferable.
For the renal lesion per se, actually radiation oncologist will be a better person, but I think for the renal lesion per se, surgery is the better thing.
Renal lesion surgery, and the other metastatic sites like bony or lung
that you can get
or liver, if it is a oligometastatic condition, we should prefer SBRT to ablate. Yes.
So, the radiation oncologists love to give a hemostatic RT. Would that work in case of a hematuria with a RCC, Puneet?
So, actually, if it's a hematuria, patient should go in for palliative nephrectomy.
Okay, that's it.
So palliative nephrectomy is
if that is not
patient is
feasible.
Sorry.
Yeah, if surgery is preferred, but if that is not feasible, embolization also works well.
Yes. Embolization is a good option.
Then yes, then you can do a lot of things. Embolization you can do then. So if the patient is having pain or hematuria, then it's a palliative nephrectomy.
Okay.
Dr. Manish has raised one question. Before doing cytoreductive nephrectomy, whether there is any role of angioembolization of the large renal mass prior to the nephrectomy?
So angioembolization actually doesn't help much for large. In fact, if you do angioembolization 1 day prior to that, then you find a lot of reaction during the surgery. So if angioembolization, we are specifically using only for those masses which are having IVC thrombus, and especially on the left side when it is difficult to attain access to the renal artery and trying not to discharge the embolus. But for cytoreductive nephrectomy as such, angioembolization is not really required.
There's another question on YouTube by, again, Dr. Aarti Sani, that is the treatment in familial RCC in a metastatic setting any different? Familial RCC in metastatic setting. Any difference? Any specificity associated with familial RCC, in terms of probably pathology, that some specific type happens in a...
Can you read out the question again, Shubham?
So she just asked for a comment on treatment in familial RCC with metastatic setting.
Familial RCC can be either some von Hippel-Lindau syndrome or some MEN syndrome. MEN syndrome more associated with papillary histology. I don't think so.
So there are actually 4 or 5 familial syndromes like Birt-Hogg-Dube, von Hippel-Lindau, and hereditary glioma and hereditary papillary syndromes. So in metastatic settings as such, I don't think if there is anything different, you treat it as a metastatic tumor only. But if it is not metastatic, then there is a difference. So then you can, because these tumors occur in younger patients and this tumor occurs in bilateral and multiple lesions. So you try and tend to do a partial as far as possible because the recurrence rate is high. From metastatic point of view, you treat it as a metastatic. And if it is an oligometastatic thing and you're doing cytoreductive nephrectomy, usually these are smaller tumors and you can do a partial in that setting.
Okay. And there's this last question again by Dr. Aarti Sani. Probably it's beyond the scope of this talk, but what is the role of adjuvant therapy in margin positive localized resected RCC? So suppose it was a non-metastatic setting and we did a nephrectomy and somehow the margin came positive, the gerotas was not completely excised or something like that. Then is there a role of any adjuvant therapy?
So I think we can combinedly take this question along with medical oncology, because I think Dr. Rajat and Dr. Indranil, there's been one trial for adjuvant therapy which initially advocated, and then it was on the long follow-up it was seen, I'm forgetting the name, something from Mel, then they were saying that it is not actually beneficial. But if you talk surgically, if you're doing a partial nephrectomy and if you have a microscopic positive margin, you don't even need to re-resect it. You just follow it up because the recurrence rates and oncological survivals are similar to what it would have been. But yes, if during the surgery, if you are going through the tumor and you see gross tumor left behind, then you should either evaluate your margin. You should again have a normal renal parenchyma, or in some cases you need to do a radical nephrectomy if there is a spillage. But if it's a radical nephrectomy and you means radiographically you don't have any other metastases or anything, and if you're seeing a girotas is involved, then I don't think adjuvant in today's date is advocated, but medical oncologist can put something.
Yeah, in microscopic disease, again, the same thing will come up that if you give some TKI, it is not going to cure the patient. It's not like adjuvant chemotherapy in some other tumor that it can take, or chemo or radiation if you combine. It's not like that. It's systemic therapy, it's going to only delay the thing and with a lot of toxicities. So better to observe the patient, and
Yes.
if there is a gross disease, then treat.
I agree with you. And even if when we are doing a partial nephrectomy, we don't do frozen sections also now.
Yeah.
So frozen section is not needed for partial nephrectomy.
I think if it's a unresectable kind of situation, you know, where you open it up and you find it that it's going into the posterior abdominal wall or a structure which you probably can't resect, we just leave clips and probably offer a radiation to it. Suppose if you open it up and you realize that
it's a very rare situation.
very rare. I agree, because most of the times
to know about it on CT.
On the imaging itself. Yes,
Yeah.
I agree. Dr. Puneet, Dr. Rajat, there are a couple of questions, new ones actually.
Yeah, so one unknown doctor has posed a question. RCC with extensive bone mets was on pazopanib therapy, and he developed brain mets while on pazopanib, and he received palliative RT to the brain. So the question is, in such cases, should we continue with pazopanib after failure in the brain, or should we change the systemic therapy? So this is a question. Indranil, if you can take it.
If the only site of progression was brain, then I will continue the same treatment.
Exactly.
If it's increasing elsewhere also, then we need to change.
So if brain is the only site of mets or progression, then we have tackled the brain adequately by giving radiation therapy, and we can continue our systemic therapy. That's the answer to this question. Another question is whether there is any role of hypoxia-inducible factor 1 alpha inhibitors in RCC in specifically von Hippel-Lindau syndrome. So HIF alpha inhibitors in VHL, proven VHL patients. I personally do not have come across any literature. Indranil, if you have got an answer to this very tough question.
If 1 alpha inhibitors, I think they are in early trials. I don't know anything else about it.
So nothing has come into the phase 3 trial basis, so hence not heard about. But nevertheless, definitely a point to consider. Shubham, is there any other questions?
No, I think we have covered most of it. Okay. Actually, I put in a question which I think you missed, Rajat. No problem. Yes. I'll just ask it. So, what is the cost difference between pazopanib and sunitinib? If we have to choose between the two on the basis of cost, what is the cost difference?
Cost difference, cost of pazopanib commercially after good patient assistance program is approximately 23 to 25,000 rupees per month, and sunitinib comes out to around 35 to 40,000 rupees per month. So it is approximately double the cost.
Sunitinib is double the cost.
Yes.
Okay. I think it covers most of our topic, and I must congratulate Dr. Indranil, because what seemed like a very evidence-heavy topic, actually when it started, by the end of it, Dr. Ghosh actually concised it all and made it what we wanted actually to hear. What is the first line, what is the second line, and the role of metastatic nephrectomy. And I think when our attendees actually go through the video of this topic, they should make note of that answer in that format, that you start by defining the incidence of RCC, the incidence of metastasis. Then you should go on to defining the pathologies, move on to the available drugs into it, probably give some important trials. Obviously, the ones that Dr. Ghosh mentioned, and the large trial of the non-clear cell type, which he summarized very well actually in one slide, the whole trial of more than 7,000 patients. And in the end, do comment on the cytoreductive nephrectomy part and the Carmina trial. I think it covers the topic extensively well, and I have learned a lot of new things today. I'm sure that I will trouble my medical oncologist a little less after seeing this talk. Thank you, Dr. Indranil. But before you go, I would want to play the answers to the quiz. I think you have covered 3 or 4 of them, but there were some questions which were related to the etiology, which obviously was not a part of your talk. And but I would want to actually give the answers out. I'll request Dr. Rajat to read the answers out. I will open the quiz, Dr. Rajat. In the meantime, can we have Dr. Geeta also with us? Dr. Geeta, if you're there. Dr. Geeta?
So, Dr. Geeta just briefly appeared and then has again.
She's here.
No, I'm there.
She's
I'm
on.
there.
Yes.
Just finished her dinner. She's wiping her face.
No, I haven't finished dinner yet. I also, it was a wonderful session by Dr. Indranil Ghosh. I think, students really look forward to clarity, because otherwise what you have is a load of information out there, but getting the right kind of clarity is very, very important. You did a great job. I think Puneet added the surgical perspective. I think you need to see together. I think he did a great job too. And of course, Rajat is our star medical oncologist chipping with it. So I think we've had a great session today, and the quiz answers will be read out now. I'll tell you what happened at the end with the quiz.
All right. So these are our answers. Dr. Rajat, you can see the screen?
Yes, absolutely.
Perfect.
So this was a very simple one to begin with. Which of the following is associated with the highest risk of RCC? It is actually smoking. Next question. So question number 2, which paraneoplastic syndrome is not typically associated with RCC? It is SIADH. It is generally seen with the neuroendocrine tumors or carcinomas. Question number 3 is renal cell carcinoma has been more commonly associated with which of the following disorders? It is von Hippel-Lindau syndrome. This was pretty easy. Next question was which clinical or lab parameter is not common between the MSK-CC and the Heng's criteria, IMDC criteria? It is actually the elevated neutrophil count. And another criteria which has been added in the Heng's criteria is the elevated platelet count. So these are the 2 new things which have been added in the Heng's criteria. So question number 5. Which immunotherapy drug has been approved for first-line treatment of metastatic RCC, either alone or in combination? When I had framed the question, I had only pembrolizumab in mind, but yes, the Checkmate 215 trial has shown that nivolumab plus ipilimumab is also one of the frontline options for first-line metastatic RCC, and pembrolizumab plus axitinib is also the first line RCC indication. So this question will have 2 answers, nivolumab as well as pembrolizumab. So that is all for all the 5 questions. And Dr. Geeta,
I know. So the answer 5 had 2 right answers.
Yes.
1 and 4.
Yes.
No. But it's no computer that we have, but only Dr. Geeta to help us out. So for the sake of simplicity,
I figured it out.
Oh, great.
So I thought, there were 13 participants this time round, and I thought all of them, but 7 of them had got 4 right. But now, because you put option 1 also as the right answer, so we've got 2 doctors who've got all the options right.
Wow.
I'll read out their names and I'll talk about those other ones who've got 4 right also, because they've also done a great job. So we have Dr. Varun Agarwal, who's a DNB student. I'm not sure which institute, but he got it right. And so did Dr. Bharat Mishra from BCHRI. So congratulations to both of you. And also to Dr. Manish Adyar, Manish Jethani from Adyar, who got 4 of them right. And so did Dr. Prasida from RCC Trivandrum, Dr. Bijan Kumar Saha from Manipal, Dr. Saurabh Jain from Prince Ali Khan, Dr. Lima Arya from Max Patparganj. So they all got 4 out of 5 right. But then, yes.
Excellent. So the 5th question actually served as a tiebreaker.
So we got 2 of them, got it right.
And another interpretation is डॉक्टर गीता का दिमाग और चाचा चौधरी का दिमाग कंप्यूटर से तेज चलता है.
Yes.
और एक और चीज कि रजत साहा जो है वो क्विज मास्टर का भी मास्टर है, तो so you know it's been a great evening, and we look forward to the next one. So the next one is going to be very, very interesting. I will definitely sit through entire thing, because you know however many times statistics is used, you know, you only learn. There is not there's nothing like a learn something, you only learn. So I think this is a great session that you should all be looking forward to. Dr. Priya Ranganathan, who's got a huge lot of experience with writing research paper and teaching people how to do it. And we will have plenty to look to on this one, which happens next week on Wednesday.
Okay. Thank you, everybody. Thank you so much. Dr. Ghosh has already left. I think it was a little late, but I think we had a wonderful talk. Thank you, Dr. Puneet. Thank you, Dr. Rajat, for joining in.
Thank you.
We'll expect much better crowd next week because of the crowd pullers that we have. Thank you so much, and good night, everybody. Good night.
Good night.
Good night. Good night.